Let me begin by offering apologies for what happened in the last session. We have had our potential incoming ACIP members listen in. They are potential candidates for ACIP membership and remain so until they are nominated by the director of the HHS. In this case, Dr. Long's microphone was unmuted and her hand went up, and I called on her by mistake. So as a reminder to everyone, the incoming members are on listen-only mode until they are confirmed as members of the ACIP. So let's move on to our next session, which is seasonal influenza vaccines. And we'll have Dr. Talbot please give an introduction.
Good morning, everyone. It's been a busy year for many reasons, but flu is never dull. Next slide. There we go. So this is our amazing group. ACIP members include our previous chair, Robert Etmar, Kevin Alt, Hank Bernstein, and Peter Szilagyi, and the remaining ex officio members and liaison representatives and consultants who all provide an immense amount of information for us. Next slide. So briefly, we'll hear today a recap of the influenza season, the 1920 influenza activity, vaccine effectiveness, and safety updates, and then we'll discuss some work group considerations and proposed 2021 recommendations. Next slide. Work group activities since June also included a finalization of publication of the 2021 ACIP influenza statement, and it was published in MMWR. Review and discussion of the 1920 estimates of influenza vaccine effectiveness, influenza disease burden, and burden averted through vaccination. Also, discussion of data from randomized control trial of cell culture-based influenza vaccine, Flucelvax, Quadrivalent among children aged 2 through greater than 2 but less than 18. Next slide. So the session overview today includes the following: efficacy results of Flucelvax Quadrivalent in subjects aged greater than 2 and less than 18 years of age, and this will be given by Dr. Greg Sylvester from Seqirus. We'll review the influenza disease burden and vaccine impact estimates of the 1920 season by Dr. Carrie Reed from the CDC. We'll have end-of-season estimates of the 1920 seasonal influenza vaccine effectiveness against medically attended influenza from the 3 U.S. influenza networks by Dr. Grosskopf, and we'll have updates and work group considerations from Dr. Grosskopf. Thank you.
My name is Greg Sylvester. I'm the Chief Medical Officer for Seqirus. And today I will present the results of our recently completed study in a pediatric population for our cell culture-based inactivated influenza quadrivalent vaccine, or CCIIV4. For the remainder of the presentation, I'll refer to CCIIV4 as Flucelvax, the brand name. Next slide, please. I plan to cover 3 main components this morning: a brief background on the merits of cell-based manufacturing, an understanding of the objectives and design of this RCT, as well as sharing the results of this pediatric study, and a conclusion slide. However, I do want to acknowledge there was a subset of participants that were part of an immunogenicity study during the 2nd and 3rd seasons. I will not present that data today due to time. This immunogenicity data was presented and discussed with the influenza work group prior to today's presentation. Today, I will focus on the efficacy and safety data. Next slide, please. Flucelvax is our cell-based influenza vaccine that is manufactured in a mammalian cell line instead of in chicken eggs. This process avoids the possibility of egg adaptation. which can occur in egg-based manufacturing. The cell-based vaccine is a closer match to the FDA-selected strains, and it has the potential for improved effectiveness compared to egg-based vaccines. Flucelvax is the only cell-based inactivated flu vaccine licensed by the FDA. The original licensure occurred in 2012 for adults, and in 2016, Seqirus was granted a new indication for 4 years and above based on immunogenicity and safety data. This today is the first efficacy study with a quadrivalent cell-based influenza vaccine in a pediatric population, and it is a post-approval requirement by the FDA. Next slide. The primary objective was to demonstrate vaccine efficacy of Flucelvax in preventing PCR-confirmed influenza in a pediatric population. This is an absolute efficacy study. Thus, we compared Flucelvax to a non-influenza vaccine. The study would be deemed a success if a predefined criterion was met. We designed and powered the study to assess the lower limit of a two-sided 95% confidence interval to be above 20%. This was negotiated with the FDA prior to the start of the study. Our secondary objective was to demonstrate vaccine efficacy of influenza in preventing culture-confirmed influenza due to any strain, as well as vaccine-matched strains. As mentioned earlier, a subset participated in an immunogenicity study, and Flucelvax demonstrated a robust immune response against all 4 strains over the 2 seasons, as assessed by seroconversion rates. We also evaluated the safety and tolerability of Flucelvax in this population, and I will share some of those results with you. Next slide. This study was a double-blinded, randomized clinical trial, controlled trial with randomization occurring in a 1-to-1 fashion. The study occurred over three influenza seasons, and the study vaccine was manufactured containing the 4 influenza strains selected by the WHO for each one of those seasons. Menveo was selected as a comparator vaccine. Menveo is a conjugated meningococcal ACWY vaccine. We chose this comparator because it was licensed for children 2 years and above. It has a dosing regimen comparable to Flucelvax and did not interfere with existing national immunization programs in the participating countries or the sites within those countries. We used standard vaccine protocol, inclusion and exclusion criteria during the enrollment phase, and we studied 2 cohorts. Participants were broken up into a previously vaccinated group and a previously non-vaccinated group. Approximately 2/3 or 3,000 subjects were considered previously vaccinated. This meant that any subject 9 years of age and older, or any subject younger than 9 years who had received 2 or more flu vaccines prior to enrollment was considered previously vaccinated. Approximately 1,500 were categorized as previously not vaccinated. These subjects were 2 to 9 years of age who had not received 2 or more doses of flu vaccine. This cohort received 2 doses of vaccine at least 28 days apart, and all study participants received a 0.5 ml dose of Flucelvax or a non-influenza comparator. Next slide. Here is a world map with the countries where our 39 clinical sites were located. There are no sites in the US because of the trial design. You've recommended a routine annual flu vaccine for all persons aged 6 months and older who do not have a contraindication. However, as you will see on the next slide, the study sites did not enroll subjects with similar race demographics as our US population. Next slide. Here are the demographics and the baseline characteristics. Both study groups are similar in age, gender, race. prior vaccine status, as well as the season in which the study participants were enrolled. If you look at the middle of the slide, you will see that the participants were Asian and white. Diversity and inclusion is important in clinical trials, and Seqirus is currently finishing a US immunogenicity trial with Flucelvax in infants and young children. In that study, African Americans and Hispanics comprise more than 25% of the study population, and I'd be happy to present those results at a future ACIP meeting. Next slide. Here are the results of the primary efficacy objective. There were 175 subjects with confirmed influenza by PCR in the Flucelvax group, and 364 subjects with PCR confirmed influenza in the control group. This calculates to a vaccine efficacy point estimate of 54.6% with 95% confidence intervals of 46 to 62%. The lower bound of the 95% CIs is well above the pre-specified endpoint of 20%, and thus the success criterion was met. Next slide. Here is a summary of the secondary efficacy results for Flucelvax against culture-confirmed influenza. The red diamonds on the graph represent point estimates for efficacy for any strain, and the actual point estimates in CI can be found in the table on the right-hand side in the middle column. The blue diamonds represent the point estimates for matched strains, which correspond to the last column in the table on the right. Efficacy for Flucelvax to prevent culture-confirmed influenza due to any A or B type of influenza strain, regardless of antigenic shift, was nearly 61%, with the highest efficacy against influenza A, H1N1, followed by any B influenza strain, and then influenza A, H3N2. As you can see, the efficacy against matched strains were slightly higher, with the majority of H1N1 and B Yamagata strains being matched. Next slide, please. This slide summarizes the percentage of study participants reporting at least one solicited local or systemic AE. Solicited AEs are recorded from 6 hours after vaccination all the way through day 7. Unsolicited local and systemic AEs were collected from day 8 all the way to 180 days or to the end of the flu season, whichever period was longer. The most commonly reported solicited local AE in both the Flucelvax and the comparator vaccine groups was tenderness, 28.7 and 25.4%. Pain, 23.8 and 19%, and erythema, 19.3% and 21.2% respectively. Except for a slightly higher rate of pain and tenderness in the Flucelvax group, no notable differences in rates of solicited local AEs were observed between the two groups. Severe solicited local AEs were uncommon, less than or equal to 1.4 in both vaccine groups, and the majority of solicited local adverse events resolved spontaneously within a few days after vaccination. As for the systemic AEs, headache and fatigue were the most common solicited AEs. These two symptoms were collected from study participants that were 6 years old and older. The symptoms of sleepiness and irritability were collected from parent diaries from children to the age of 6 years of age. Severe solicited systemic AEs were uncommon and generally less than 1%. There was one death that occurred within the control group. The child died of cerebral edema caused by diabetic ketoacidosis. This death was carefully reviewed and deemed not related to the vaccine in the control group. Not shown on this slide are the reported unsolicited AEs. The unsolicited AEs, both for local and systemic, were also similar amongst the two groups. This study's safety profile is similar to our previous immunogenicity Flucelvax study in children 4 and above. And then finally, the conclusion slide. Next, please. In conclusion, this is the first efficacy study in a pediatric and adolescent population with a cell culture-based quadrivalent influenza vaccine. The overall vaccine efficacy was 54.6% with tight confidence intervals, and Flucelvax was well tolerated with similar rates of solicited and unsolicited AEs between the two vaccination groups. Thank you for your attention, and I'd be happy to answer any questions.
Thank you very much for that presentation, Dr. Sylvester. It's open for questions at this time, members of the committee. Dr. Szilagyi, I see your hand is up.
Yes, thank you, Dr. Sylvester, for a very clear presentation and nice results. Could you give us information about the VE across seasons, since I think you gave us data that combined 3 seasons? And also, did you do any subgroup analyses by smaller age groups?
Yes, so if you'll go to my first backup slide, I might be able to answer your first question. So here actually is the absolute VE by season. Now don't forget, season 1 is the Southern Hemisphere. Season 2 is the Northern Hemisphere, Southern Hemisphere 2017. Season 2 is the Northern Hemisphere 17-18, and season 3 is the Northern Hemisphere 18-19. You can see that the for overall in season 1, it was 56.5 for any strain. For season 2, 44%, and for season 3, 59%. And then I have the breakdowns whether it was H1N1, H3N2, or one of the type Bs.
Okay, thank you. And a question did you do subgroup analyses by age?
So we did, and we actually looked to see whether there was a difference between the previously vaccinated and the non-previously vaccinated. And we broke down, and we did not see a difference, so that they were similar.
Okay, thank you.
Dr. Kimberlin.
David Kimberlin, AAP Red Book. You mentioned on slide, and this may be an extension of what you just said, but just from a trial design standpoint, on slide 5, you mentioned that about 2/3 of study subjects were previously vaccinated and about 1/3 were not previously vaccinated. Was this a stratified study? In other words, what was the randomization within each of those 2/3 and 1/3 evenly spaced between active influenza vaccine recipients and placebo recipients?
Yes, thank you. And I don't think I was very clear with that. So within each strata, so that if in the previously vaccinated, which had about 3,000, they were relegated to either receiving the comparator or Flucelvax. And within the 1,500 not vaccinated, they received 750 got Flucelvax and the other got the comparator.
Thank you.
Dr. Whitley Williams, please.
Yes, thank you very much. Thank you, Dr. Sylvester, for that presentation. You mentioned that there is a study going on in the US at present, which involves the pediatric population, more similar to the actual diversity in the population in the US. Can you anticipate when data from that trial would be available and for the ACIP to review?
Certainly. So I will say that this trial that I have just shared with you has been submitted to the FDA. We call that, a supplemental BLA. And we're hoping that this trial will hear from the FDA, whether it's approved or not, down to the age of 2 and above this January 2021. But the data that I referenced we're hoping to submit the SBLA in March of next year. So once we submit it, I'd be happy to come to the work group and share the data prior to, and then I think that I could certainly be there in June to be present the full data to the entire ACIP.
Thank you.
And that's down to 6 months of age, 6 months up to the age of 4, and it is an immunogenicity study.
Thank you. Dr. Paling.
Hi, thank you, Dr. Sylvester, for this presentation. I wanted to ask a clarifying question. For your previously not vaccinated group, did you still use the 2 doses 1 month apart for those children?
So previously non-vaccinated, yes, they would receive 2 doses of the 0.5 ml vaccine, so that if it was in the Flucelvax, they would receive it on day 1 and then again on day 28. If they were in the non-comparator, they received Menveo as their first vaccine, and then they got a saline solution placebo for their second vaccine.
Thank you.
Are there any other questions from the voting members or from the liaisons? I see none. Thank you very much, Dr. Sylvester. We'll move on to the next presentation by Dr. Reed on influenza disease burden and vaccine impact estimates 2019 to 2020 season. Please go forward, Dr. Reed.
Thank you. Good afternoon. Next slide. CDC tracks flu activity in the United States in a collaboration with state and local health departments using multiple surveillance systems in 5 different surveillance categories. Together, these systems are designed to provide a national picture of flu activity, including how much flu-like illness there is, the distribution of virus types and subtypes, and trends in flu-related hospitalizations and deaths. Next slide. You've seen summaries of the 2019-2020 influenza season at previous meetings, but as a reminder to provide context to the rest of the presentation, this slide shows some data from influenza testing in clinical laboratories that are reported to CDC. The graph on the left shows the percent of tested specimens that were positive for influenza overall for the 2019-2020 season in red compared to previous influenza seasons in gray. Influenza positivity began to increase in early November of 2019, peaked in week 6 in February, and then declined rapidly in March, faster than in recent previous seasons. The graph on the right is stratified by positivity for influenza A and influenza B viruses separately to illustrate that the early season activity with influenza B and then the later increases in influenza A activity. Next slide. These graphs show the distribution of influenza virus types and subtypes for the 2019-2020 season. They're on the left compared with recent prior seasons. This is based on influenza testing done and reported to CDC from public health laboratories. The 2019-2020 season was predominated by influenza A, H1N1, and influenza B Victoria viruses. In comparison with recent prior seasons, there was very little H3N2 virus activity. Next slide. For a number of reasons, however, these surveillance systems that we use to monitor flu activity do not capture every flu-related illness, medical visit, hospitalization, or death in the United States. And we at CDC feel like it's important to convey the full burden of seasonal flu and the reductions in disease burden that occur because of influenza vaccination in the US. And so today I'm presenting on these 2 additional activities that use those surveillance data collected through our routine systems and other key influenza platforms to answer some key questions about influenza disease burden and the impact of flu vaccination in the population. Next slide. One of those key questions that isn't measured directly in surveillance is how many people get the flu every year, and by extension, how many people are hospitalized and how many people die. Next slide. Measuring this directly in surveillance presents many challenges, and we often consider the cases, hospitalizations, and deaths that are confirmed to be influenza and reported to public health agencies and CDC to be the tip of the iceberg. This can be for a number of reasons. Outlined here are just some of those reasons. Not all sick people seek medical attention for their illness. Symptoms are similar among pathogens, and so unless they're confirmed with influenza testing, we don't know for sure if those are flu illnesses. People may not be shedding virus by the time that they're tested. Complications may be broader than respiratory illnesses and not recognized or thought to be flu and not tested. And even when it is confirmed, it may not be recorded on a death certificate, et cetera. Next slide. So for example here, thinking about why not all cases are detected and how that impacts on what we know about. For example, somebody who's hospitalized with influenza, next slide, when they present for care, they may be tested for influenza or they may not be tested, in which case in gray on the left, we wouldn't know about them. Next slide. Next slide. One more. There we go. Thanks. If they are tested for influenza, there's a variety of tests that could be used with a variation in sensitivity between tests. And so some people who are tested may test positive, but there may be some people who are falsely negative on their test result. And so next slide, please. What we know about in our surveillance systems are these positive influenza tests. They're outlined in red at the bottom. And in order to get back to what we want to know, which is the total number of hospitalizations, we collect information on some additional factors, such as the test sensitivity, the distribution of the types of tests that are used, and the percent of patients in these settings, such as hospitals, that are tested for influenza. And using these additional pieces of information, we can mathematically work back to what the total number of influenza hospitalizations there in dark blue would be, given the number in red that we have observed in our surveillance. Next slide. And so this is an illustration of the method that we use to estimate the disease burden, the number of illnesses, hospitalizations, and deaths that we observed during an influenza season. We developed this method originally during the 2009 pandemic and have refined it over the last several years to be able to monitor this disease burden during the season based on our routine surveillance systems. The key system in this process is our Influenza Hospitalization Surveillance Network, or Flucelvax. They're indicated in yellow. And then we go through several other steps to be able to extrapolate that to the US population and then make estimates both of deaths and illnesses and medical visits in addition to hospitalizations. Next slide, please. So to do that, we collect some additional information. Next slide, please. One is factors to correct for underdetection. Like I outlined on the previous slide, identifying influenza testing in hospitals and test sensitivity to be able to correct for those missed hospitalizations. And then these two other pieces of information. Next slide. Sorry, one more and another one. There we go. Where we also collect some additional information there for number 3. We monitor the risk of dying in a hospital setting from influenza in our hospital surveillance network also. And then we know that some people die outside the hospital, so we collect additional information from death certificates on the proportion of deaths that occur outside of the hospital to capture the full number of deaths, both in and outside of the hospital. And then number 4 there, we have data from previous flu studies on the risk of hospitalization to estimate how many symptomatic illnesses were in the population given the estimates of hospitalization, and then some additional information on medical care seeking behavior to estimate medical visits. And these methods have been, as I mentioned, refined over time, and they've been published in the scientific literature, a couple citations down there in the bottom right corner. Next slide. Following that methodology, these are the estimates for the 2019-2020 season: 38 million illnesses, 17.5 million medical visits, 400,000 hospitalizations, and 22,000 deaths. This is overall for all ages. We do estimate this in 5 age groups, and those detailed estimates for this past season, as well as all seasons since 2010-11 season, are on our website. Of note, these estimates are preliminary. We consider them to be preliminary because some of those inputs I mentioned on the previous slide can be lagged in time. And so we use data from previous seasons until those can be finalized. Next slide. This is a screenshot of the website that I mentioned. We updated this a few years ago to present a lot more information. We have information here at a high level on how and why CDC estimates burden. We have a link to the tables with the detailed estimates by age group and by season for all past seasons on the website. And there's also a place where you can go to see those preliminary in-season estimates that we update weekly throughout the influenza season. Next slide. The second question that, again, is not directly estimated in any of our platforms is what impact can our interventions have, specifically vaccination, in terms of reducing disease burden in the population? Next slide. Influenza vaccination is the primary strategy that we have to prevent influenza illness and complications. We all know that vaccine coverage, effectiveness, and rates of influenza can all vary between seasons, between age groups, between different types and subtypes of influenza viruses. And so a few years back, we started through the process of what I'm going to talk about for the rest of this talk. At the end of each flu season, we use data available on all of those factors, on coverage, on effectiveness, influenza disease burden, to estimate the burden of flu that was prevented by vaccination in order to better describe the population of impact of influenza vaccination in the US. Next slide. So for the 2019-20 season, these are the components that went into that analysis, the disease burden estimates that I just outlined. These are estimated by age group and type and subtype. We also use data on vaccine coverage. This varies by age group and by month over the course of the season from our colleagues in the Immunization Services Division. And then data on influenza vaccine effectiveness, which also varies by age group and flu type in this analysis. And these are from the US Flu Vaccine Effectiveness Network. Next slide. Pulling those pieces of information together, these were the estimated influenza averted burden from the 2019-20 season. 7.5 million flu illnesses prevented, 105,000 hospitalizations prevented, and 6,300 flu deaths prevented. A few years back, our communications group started using analogies, some of which are presented here, to try and communicate the magnitude of these estimates and the amount of flu disease that was prevented by vaccination. Next slide. We also calculate the prevented fraction, or the proportion of potential flu cases that were prevented because of vaccination. So for example, in this case, we estimated that 21% of all flu hospitalizations were prevented. That's that 105,000, or 1 in 5 flu hospitalizations didn't happen because of vaccination. This fraction was highest this year for the age group 6 months to 4 years. 28%, or over 1/4 of hospitalizations were prevented by flu vaccine. Next slide. So in summary, during the 1920 season, there were an estimated 38 million people sick with flu, resulting in 18 million visits to a care provider and 400,000 hospitalizations and 22,000 deaths. These estimates were lower than some recent seasons, but similar to other seasons where influenza H1N1 viruses predominated. Although overall they were lower than some recent seasons, persons under the age of 50 years had rates of illness, hospitalizations, and deaths that were similar to or greater than the 2017-18 season, which was a recent season with high severity. And finally, vaccine prevented the greatest proportion of outcomes among that youngest age group, children aged 6 months to 4 years, which is an age group that had high vaccine uptake and the greatest vaccine effectiveness during last season. Thanks.
Thank you very much for that presentation, Dr. Reed. It's open for questions at this time. Dr. Szilagyi?
Yes, Dr. Reed, thank you. This was a really clear and excellent presentation. And for several years now, I've been pointing out that it would be really great to demonstrate or to show data about disease averted by the vaccine. And I think this is a wonderful way of doing it. Two questions. I believe your analyses don't account for herd immunity. And I'm wondering whether there may be some modeling and additional analyses that could account for herd immunity, although I may be wrong, although I think it doesn't. And the second is did you say that you used the vaccine effectiveness data from the Flu VE network for all types of care, including hospitalizations, extrapolated? Because now with the three platforms, with VE Network, Haven, and NVSN, it may be easy, good to hone in on the actual VE from the different types that are specific to outpatient ED or hospitalizations. And the last comment is to look at ED visits. I think that would be really good.
Yeah, thanks for the question. First question, you're correct. This does not include any indirect effects of herd immunity from reduced susceptibility in the population. So this is benefits directly to people vaccinated, not from any additional herd protection in the population. That is a question that we're examining with some modeling colleagues, but not currently included in this analysis, but hope to be able to refine that and include the additional benefits from in the population in the future. Second question was, I should have written that down. Sorry, what was your second question? Oh, VE. Yes, right now we've included the VE, a single VE from the Vaccine Effectiveness Network. The assumption in the analysis is that if you prevent flu, you prevent downstream consequences from flu. So we don't have separate vaccine effectiveness for hospitalization or death. But you're right, if there is additional attenuation from vaccine, that is something that we would build into that in the future, adding a different vaccine effectiveness against the hospitalization or death outcomes.
Great, really well done. And then just a comment I had is you may consider looking at ED visits as well as we get more and more data about the burden of disease in ED and the potential impact of the vaccine on averting ED visits. So
yeah,
excellent job.
We've talked about that. We just haven't gotten to it yet.
Thank you. Dr. Fry.
Thank you. Thank you for a great presentation. I wanted to ask a question about the 2021 flu season. And I was wondering if you could share your thoughts about the effect of what COVID and mask wearing or COVID infection and mask wearing might have on the ability to effectively estimate flu burden.
Yeah, we've been talking about that. We did see at the end of last season that flu activity decreased faster than it had in previous seasons, likely in part due to the COVID interventions and restrictions that were in place in March. So we have discussed how to monitor flu burden this season. We're going to continue to rely on our hospitalization platform, which is continuing to do case finding for flu this season. I think one of the key factors will be how flu testing in the clinical setting is influenced, and so whether we're detecting flu cases at the same rate that we usually do. And so we have some work ongoing to better monitor how flu rates of hospitalization and also testing practices and our detection of flu in medical settings is changing during this coming season. So I think it will be a challenge, but yeah, we're trying to figure out how to appropriately monitor and assess the detection of flu this season.
Thank you.
This is Jose Romero. Let me tack a question onto that question that Dr. Fry was asking. So with the availability of combined COVID influenza testing, will that give you a better idea, or will that confound your evaluation in this coming season?
Yeah, good question. I mean, that's one of the things that we're trying to collect through some various platforms, is not just flu testing overall and COVID testing rates overall, but also the subset that are being tested for both, and whether or not they're more likely to be positive for one or the other, and what are some of the factors associated with that. So yeah, definitely something we're trying to keep a close eye on this season.
Thank you. Dr. Bernstein.
Yes, thank you. I agree with my colleagues. This was an impressive presentation, and these data do convey valuable messaging for the public. And along those lines, in the last two questions from Drs. Fry and Romero, is this model, which has been published, used by other countries, particularly in the Southern Hemisphere, where SARS-CoV-2 and influenza have already co-circulated?
Yeah, we have worked closely with our international colleagues in the past on applying our averted burden model. We've had many colleagues in the Southern Hemisphere that have been using similar methods to estimate averted burden for flu. We have not worked with them specifically during this past season. In many parts of the world, flu activity in the Southern Hemisphere was relatively low during this season. But in past seasons, yes, this method has been used in other places.
It might be helpful given the current pandemic.
Yeah, thanks.
Dr. Lee.
Thanks very much. I wanted to echo my colleagues' comments, and I'm really glad to see the information presented in this way in terms of disease burden and preventable burden. And I'm going to just say that I hope we can do the same for COVID vaccines. A couple of aspects that I wanted to perhaps dive a little bit deeper on are the estimates around detection. So the estimates are dependent on people getting tested. Have you considered ways to account for perhaps disparities in testing and vaccination, and also how that might impact our disparities in the estimates for disease burden? I feel like we're learning a lot from COVID, and I think thinking about how to account for that might be really important, because we might be underestimating even more significantly, putting aside herd immunity. And then my second question is related to pregnancy. So similar, along the same lines, I feel like it would be extremely helpful for us to understand the burden of disease in pregnant women and the preventable burden through vaccines. So would encourage the team to see if we can try and actually capture those estimates as well, both for flu vaccine and potential future COVID vaccines.
Yeah, so for your second question about pregnancy, we have an analysis very similar to this, but for pregnant women specifically, that got sidelined a little bit when we started into the COVID response. So that is still in progress. We hope to have that out relatively soon. So same methods, but specific to the population of pregnant women. And then your first question about disparities. Yes, this has come up recently, the more that we've understood the disparities, especially racial and ethnic disparities in COVID burden. We have gone back and stratified those hospitalization rates that I mentioned by race, ethnicity, and are thinking about what other inputs we would need to understand better, especially the testing practices, and how we could understand that better by race, ethnicity in order to understand disparities in burden. So yes, we also have had similar questions and are thinking through how we might modify this to get more at specific populations, both pregnant women and then also specific other populations that may be disproportionately affected.
Ms. Bata.
Thank you. I think Grace pretty much said what I wanted to say. This data is used at our state level for messaging about the importance of influenza. So thank you for that. And it would be really helpful once we start getting data regarding COVID disease to be able to message how vaccination could help mitigate. Thank you.
Thank you.
Dr. Ault.
Yes, can I go back to the pregnancy modeling a little bit? Does that include does your proposed model include preterm delivery and other obstetrical complications of influenza infection in pregnant women?
Right now, we haven't. We've had those discussions. Right now, it's just similar to what I presented before. So illnesses, medical visits, hospitalizations, and deaths in pregnant women and their infants who have potentially residual protection from vaccination. But we haven't gotten yet into some of those other outcomes, the pregnancy outcomes specifically.
Dr. Hunter.
Thanks. Hang on, I just got to do a little unmute. So I'm given the need, I guess the situation in clinical practice of upcoming our current flu season of differentiating between COVID and flu. I'm wondering if there's going to be any a recommendation or guidance on a national level to do more flu testing this year than we would do in most years? And if so, how would that tie into the availability of supplies, since I assume that increased flu testing would use similar reagents as the COVID testing? Thanks.
Yeah, thanks. I think we've heard comments from folks in our surveillance sites that are having similar questions about how to prioritize testing if supplies are limited. I can't speak to the current status of those discussions about recommendations. Perhaps there's others who could get back to you on that with more specifics.
Thank you.
Dr. Szilagyi, I see your hand is still up. Is that just left over? Or did you have another question?
Sorry about that. No other questions.
Very good. Liaisons, any questions? Dr. Stinchfield.
Yeah, this is Patsy Stinchfield, NAPNAP representative. Just to the last question, our testing of COVID to date has mostly been single antigen Cepheid tests, and those will be going away in our area in a couple of weeks here, and then go to a 4-plex test. So it'll be influenza A, influenza B, RSV, and COVID. And so we are certainly planning on having more data than we normally do because of the need to rule out COVID versus flu in children. So we'll be watching that and happy to share that information later.
Thank you. Dr. Goldman.
Thank you, and forgive me if I missed it, but is there any modeling or data or studies suggesting vaccine effectiveness in preventing disease and the timing of when the vaccine is administered, early or late in the season?
There was one analysis published by our group, Ferdinand's et al., recently that looked at that a little bit. I know there's some ongoing interest in refining models around that as well.
Dr. Schaffner.
Thanks, Jose. Speaking as medical director of the NFID, the National Foundation for Infectious Diseases, a couple of quick comments. Due to the increasing number of COVID-19 cases, the 2021 flu season is likely to be very challenging. And many of the same individuals who are most vulnerable to serious complications of COVID-19, including older adults, members of minority groups, and those with certain chronic health conditions, also are at greater risk for the complications from flu. And to address this public health issue, NFID convened a multidisciplinary roundtable to explore the potential impact of influenza and COVID-19 on adults with chronic health conditions. Outcomes from the roundtable are summarized in the NFID call to action, which is available on the NFID website at www.nfid.org/flu. All of us as healthcare professionals are encouraged to use the strategies in the call to action. We can save lives and reduce hospitalizations, as well as the overall burden on the healthcare system. Let's just vaccinate. Thank you.
Thank you, Dr. Schaffner. Any other questions or comments? Excellent presentation and wonderful comments. We'll move on to our next presentation, which is by Dr. Groskopf on end of season estimates 2019-20 seasonal influenza vaccine effectiveness against medically attenuated influenza from 3 U.S. networks. Dr. Groskopf.
Okay, I'm presenting this work on behalf of others, the investigators who did these, who do this great work. So I just want to thank all of them briefly. For this first slide, we have 3 different networks we're going to discuss today. These are used to estimate annual vaccine effectiveness against laboratory-confirmed medically attended influenza in a variety of settings and for a variety of ages. Next slide. The U.S. Flu VE network enrolls children and adults from ambulatory settings with acute respiratory illness, including cough. This network consists of 5 sites in Washington, Wisconsin, Michigan, Pennsylvania, and Texas. And the principal investigators are shown on this slide, and you'll see a similar format in the next couple of slides. Next slide. The hospitalized adult in influenza VE network enrolls hospitalized adults with ARI, including cough or worsening cough or sputum production at 4 sites, including Michigan, Pennsylvania, Tennessee, and Texas. 3 of these sites overlap with those of the Flu VE network presented just on the last slide. Next slide. And the new vaccine surveillance network enrolls children in the inpatient setting as well as those who have emergency department visits without a hospital admission who have 1 or more defined respiratory signs of symptoms at 7 sites. Next slide. The methods overall for these networks are similar. They use a test-negative study design to estimate VE by comparing the odds of influenza vaccination among people with laboratory-confirmed influenza by RT-PCR versus those who test negative for influenza who serve as the negative test-negative controls. Vaccine status was defined by receipt of any licensed 2019-20 seasonal influenza vaccine at least 14 days prior to illness onset. Vaccination status was ascertained using a variety of sources, including medical records, immunization registries, and/or self-report. VE is estimated as 1 minus the adjusted odds ratio of receipt of current season influenza vaccination in cases compared to controls times 100%. These analyses are adjusted for a number of potential confounders such as study site, age, calendar time, and baseline health status. Next slide. Tables on this slide show the periods of enrollment for each network during the 1920 influenza season, the number of patients enrolled, and the number and percentage of those who tested positive for influenza by RT-PCR. The U.S. Flu VE network enrolled patients between November 2019 and March 2020 with 31% testing positive for flu, Haven between October and March with 18% testing positive, and NVSN shown here separately for the hospitalized children and the children evaluated in the ER, 17% testing positive in the inpatient settings and 32% in the ER. Next slide. The next 3 slides just give you an idea of the relative distributions of the different types and subtypes of influenza viruses in the networks. The VE analyses included participants enrolled during each site-specific influenza season, and the season was defined as the dates of the first through the last influenza-positive case among the enrolled patients at each site. This figure shows the number of patients enrolled and their influenza test status by week for NVSN. This season for NVSN was characterized by early circulation of B. Victoria viruses, represented here in the light green bars, AH1N1 PDM09 viruses, which came to a peak later, represented by the orange bars. They circulated later in the season. Next slide. This slide is a similar depiction of data for Haven, which is, again, all adults. In this hospitalized adult population, there are relatively few influenza B cases, represented again by the green. This is typical of the disease patterns in adults, and most of what we did see of B was observed early in the season, with overall a majority of AH1N1 PDM09 viruses represented by the orange bars. Next slide. This slide shows influenza infections in the ambulatory U.S. Flu VE network, which includes, again, both children and adults. And in this network, most early season influenza cases were from B. Victoria viruses, followed by a predominance of AH1N1 PDM09 during the second half of the season. Of note, and you'll have noticed this on the previous slides, there was very little H3N2 activity observed in any of the VE networks for this season. Next slide. So next we'll briefly present some VE results for the 3 networks. We'll start with the U.S. Flu VE network. Next slide. Preliminary estimates from the U.S. Flu VE network were initially presented at ACIP in June. Final end-of-season estimates shown here are pretty similar to these previous estimates. Overall VE against medically attended A and B influenza viruses was 39%. BA was slightly lower than expected for H1 viruses at 30% and slightly higher than expected for B Victoria at 45%, particularly since most of the B viruses were antigenically drifted from the vaccine component. Next slide. This slide shows VE for B Victoria by age group. Point estimates were overall fairly similar across age groups with overlapping confidence intervals. Next slide. For H1N1 PDM09 viruses, VE was relatively low across all age groups shown here compared with prior seasons. There was some suggestion of some variability between different age groups, with VE ranging from 22 to 42% and being the lowest in children. But again, confidence intervals overlap. Next slide. For our next section, VE estimates against influenza-associated hospitalizations and ER visits from NBSN, which again is a pediatric network. Next slide. This slide shows VE in children by virus type, further stratified by inpatient versus ER setting. Overall, VE in children was relatively high at 62% against hospitalized influenza-associated illness and 56% against medically attended illness in the ED setting. For H1N1 PDM09 viruses, this was 64% against hospitalized illness and 53% in the ED setting. For B Victoria viruses, estimates were similar in inpatient and ED settings at 54 and 55% respectively. Next slide. This slide compares VE estimates for children from the ambulatory network, US Flu VE, to the inpatient and ED estimates presented on the previous slide for NBSN. Higher VE was observed in the inpatient and ED settings compared with the ambulatory settings, which was most noticeable for H1N1 PDM09 viruses. The group plans to look at this geographically, geographically overlapping sites to see if they can still observe the same trends restricted to similar geographic areas. Next slide. This slide shows further inpatient, ED, and outpatient VE estimates for children within the more restricted pediatric age categories. The VE estimates on the left box of this slide are the same as those shown on the last slide, broken down by 6 months to less than 5 years and 5 through 17-year age groups. Similar trends were observed with overall lower VE seen in the ambulatory network. Next slide. Lastly, Haven. This slide shows estimates of VE against influenza hospitalization by virus type side by side with estimates previously shown for adults enrolled in Haven. VE estimates were similar between the inpatient and ambulatory networks. In hospitalized adults, an overall VE for A and B virus of 41% was seen. VE for H1N1 PDM09 was 40%. VE for B viruses was 33%, but with wide confidence intervals due to the small number of B cases among hospitalized adults. Next slide. This slide shows VE against influenza hospitalizations and outpatient visits in Haven and US Flu VE respectively among adults in 3 non-overlapping age groups. Within each age group, confidence intervals for VE estimates in the inpatient and ambulatory settings overlapped. For hospitalized adults, VE surprisingly was highest among adults 65 years and older with a point estimate of 54% and lowest and not significant in young adults 18 through 49 years of age with a non-significant VE of 16%. Next slide. So next brief discussion. Some limitations. The VE networks, next slide, sorry. VE networks are subject to a number of limitations. In particular, networks are limited in their ability to assess estimates of VE by specific vaccine types, and we have a number of them for influenza for the 1920 season. Notably, there was limited use of LAIV in children, as well as the existence of site-specific difference in use of vaccine types offered to patients when you compare the different sites. Further, some results, including VE for partial versus full vaccination status among children under 9 years of age, is pending confirmation of final vaccine receipt data. Next slide. In summary, during the 1920 influenza season, vaccination was significantly protected against medically attended influenza-related illness across all networks. Despite vaccine mismatch, vaccination offered important protection against B viruses in children for whom B viruses tend to be associated with severe disease. In children, VE trended lower for ambulatory compared to inpatient and ED settings, which warrants additional analysis, whereas outpatient and inpatient VE were similar for adults. And the next slide, followed by the next 3 slides, are acknowledgements for these groups, which will be seen in the public posting. So thanks very much. I have a very few 4 slides for the next talk, but probably makes sense to pause here for questions. Yes.
Yes, thank you very much, Dr. Groskopf, for that very good, but interesting presentation and thorough. Any questions? Dr. Stinchfield, I see your hand is up. Dr. Stinchfield, your hand is up. All right, move on to Dr. Kimberlin.
Yes, David Kimberlin, AAP Red Book. Can you go to slide 17 or 18, right in that range? This is, I think, just for my clarification.
I think so.
All right, so the header of this says NVSN/flu-VE. Is that the flu-VE network, or is that influenza vaccine effectiveness from the NVSN?
That is a comparison between the 2 networks. One is outpatient, so the U.S. flu-VE network is outpatient. So you have hospitalized versus emergency department within NVSN, and outpatient would be the U.S. flu-VE network.
And that the same would hold true for the next 4 slides or so, correct?
Correct, where it refers to outpatient.
Yep. All right, thank you.
Dr. Lee.
Thanks so much for that excellent presentation. And Dr. Groskopf, I think you talk faster than I do now. So one of the things I wanted to ask specifically was whether or not you have any information about background rates of community vaccination in the communities in which these individuals are coming from, and whether there are any differences in sort of distribution of communities by outpatient versus hospitalized ED status.
For that question, if Dr. Flannery is on the line and can unmute, I think I'd like to refer that to him.
And just for clarification, as Dr. Flannery is coming on, I think that, it relates to the question from the prior session that I think Dr. Szilagyi brought up around how much herd immunity can we account for. I recognize these studies are really focused on direct protection, but just trying to understand the variability in the background.
Yeah, so in the U.S. flu-VE network, many of the sites have a population that's enrolled in a health system. They're likely to be more vaccinated than the general population in those areas. That's also true because of the overlapping sites with the inpatient adult network. But the NVSN network enrolls at children's hospitals where not all of them are drawing from source populations and may be more reflective of vaccine coverage in children. When we compare the U.S. flu-VE network and some of the other network data in the control group or the influenza negative group, we tend to see that the vaccination coverage in the flu negatives is higher than the survey-based estimates for those areas. But again, that may not be the case with the NVSN hospital and ED networks, and we'll have to look into that with that group. Over.
Thank you.
Ms. McNally.
Thank you. Thank you very much for this presentation. Also very helpful. I'm just wondering from the consumer perspective, if there has been any discussion with your team regarding potential ways to evaluate VE for the LAIV4.
I'm gonna offer. This is Dr. Groskopf. I'm just going to offer a partial answer, and I'll ask Dr. Flannery to chime in. Also, uptake of LAIV4 has not been terribly high in the last couple of seasons, which does somewhat limit the ability to detect VE. I don't know if Dr. Flannery has any other input.
Just that we are tracking the vaccine effectiveness from other networks. The best data are from the United Kingdom, which several years ago when we had some comparisons between the US data and the data from the United Kingdom showed slightly discordant results. So we do not have data from other networks right now for LAIV effectiveness against H1N1. And as Dr. Groskopf said, the uptake in the networks, both in NBSN and in the Flu VE network, has been low at those sites, and we haven't been able to have an estimate for LAIV, either overall or for H1N1. Over.
Thank you.
Dr. Hunter.
Thanks. I've got a two-part question. If the flu vaccine is preventing hospitalizations more than all medically attended infections, does that mean that some vaccinated people might be getting mild symptoms, and then if they're continuing their social interactions, resulting in some transmission? So that's the first part. And the second part is, if that's right, then what is the role of physical distancing and masking in future flu seasons? Thanks.
I don't have a specific answer for that. I mean, it is conceivable that people may have relatively mild or subclinical illness. Some people do get infected with influenza and not have much in the way of symptoms at all. That does happen. And that does not mean, however, that they're not contagious. I would think it remains to be seen what sort of effect, for example, the current mitigation measures that are being employed to mitigate spread of COVID might affect influenza as well. And it would be difficult to speculate on whether those would be, it would be desirable to employ those specifically to prevent transmission of flu at this point.
Thank you. Dr. Flannery.
No, I'm sorry. I raised my hand so that I could unmute, but I didn't have a question.
Thank you. I'm sorry. Dr. Hayes.
Yes, anecdotally, I know a couple of people that got a prescription called in for treatment for flu without ever getting tested. And I'm curious if you're monitoring prescriptions in addition to monitoring testing.
At least within this activity, not monitoring prescriptions, the recommendations for the use of antivirals for influenza generally state that if the clinician believes that it's flu and the person falls into a category for which the antiviral would be indicated, for example, people that are high risk of severe illness, that testing isn't required, or it even is stated that you should not wait for the results of a test or use the results of a positive test if it appears to be influenza on clinical suspicion. I'm not aware of the proportion of individuals that don't get tested but nonetheless get a prescription.
Actually, I think I was asking if so that's an untested person that probably had the flu but got treated. So what I'm asking is, are we monitoring the sale and the number of anti-influenza medications as a way of monitoring the cases?
I'm not aware that we're doing that, but let's ask somebody else here.
This is Dr. Cohn. I can answer somewhat. We do monitor prescription medications, but more so from the perspective of monitoring them for potential shortages of those medications. We haven't used that as a way to way to look at potential influenza disease, but we can definitely take that back and think about it.
Any other questions? Okay, seeing none. Dr. Groskopf, take us out with updates and work group considerations.
Okay, this is just a very brief couple of slides. There have not been any policy changes associated for this meeting, so there's not much to say, but there are a couple of pertinent updates. First, on this acknowledgement slides, just thank you to everybody. In addition to our work group members who really have been great about their amazing contributions to our group despite these exceptional times that we're all having. In addition to thanking those individuals, I want to thank our CDC attendees that contribute to our calls. And also, I want to thank Robert Atmar for his leadership as our chair for this past period of time, which has been a very demanding one for everyone. I'm grateful for having worked with you, and welcome to KIP. Talbot, Dr. Talbot. Okay, next slide. Very brief distribution update. It's estimated or projected that approximately 194 to 198 million doses of influenza vaccine will be distributed this season. These curves show the distribution for the last several seasons by calendar month and week at the bottom on the x-axis. The green line, pale green line coming in from the left, represents the current season, so you can get an idea of the approximate number of doses distributed relative to previous seasons. As of October 16th, 154.6 million doses have been distributed. Next slide. Very briefly, just two current season surveillance slides. The take-home point is that influenza activity in the United States is currently low. These are the virologic surveillance results that you can see on FluView. Those big multicolored peaks with the colored columns are not our current season. Those are last season, and our current season is represented by the inset with the brackets in each case, with the public health laboratories by calendar week on the left and the clinical laboratories on the right. The line across the graph for the clinical laboratories indicates the percent of specimens positive, and right now that's at about 0.3%, so not a lot of activity being picked up. Next slide. Similarly, this is also from FluView, same week. The most recent reporting week is week 42, the week ending October 17th. This is data from ILINet. A number of seasons represented here. This is probably a familiar graph by now. Each is a different colored line. The current season is the line with the triangles off to the left, and you can see that we have very little ILI activity being reported through this network, even relative to other recent seasons. Last slide. So as far as work group discussion and considerations relevant to the materials and topics that we presented today, the work group had an opportunity to hear and discuss the presentations of burden, averted burden, and VE that you heard, and also had the presentation of the data from the trial of Flucelvax quadrivalent for children aged 2 through 17 years. Overall, there were some clarifying questions asked during the discussion about the design and the study population, but no specific concerns were raised, and we'll be following this as we go through the year into next year. And that's all I have for today. Thank you.
Thank you very much. Are there any questions or comments for Dr. Groska? Dr. Hunter.
Yeah, going back to my other comment about testing for flu, my impression, and Dr. Groskopf, I'd be interested in your reaction to my impression, which is that if the very low rates of flu that are currently going on are representative of what's happening in clinical practices, which it seems that it is from what I've heard, and how representative your samples are, then I don't see a real strong reason for clinicians to and for health systems or public health to spend a lot of resources or divert resources from testing of COVID towards testing for flu at this point. Do you have any comment on that?
Only that I think that with flu, we know one thing we can anticipate is being surprised and not being able to necessarily predict activity, and we don't really know what's going to happen for the remainder of the season.
Absolutely.
Any other questions from the work group or the liaisons? Okay, I see none. All right, then we are going to break for lunch. We'll have half an hour for lunch, so we will reconvene at 25 to the hour, and we'll see you then. Thank you very much.